The topic for today's discussion is Stevens-Johnson syndrome. We'll be discussing introduction, features, and treatment. Starting with introduction. The terms Stevens-Johnson syndrome, or SJS, and erythema multiforme major have historically been used synonymously. However, it is now believed that erythema multiforme without the major is a distinct disease, milder and recurrent, with somewhat dissimilar clinical feature. The other variant topic, which is toxic epidermal necrolysis or Lyell syndrome, is a severe variant of Stevens-Johnson's. Patients with toxic epidermal necrolysis tend to be young adults, though other groups may be affected. The condition involves a cell-mediated delayed hypersensitivity reaction, which is usually related to drug exposure. Mortality is overall high in Stevens-Johnson's and is around 5%, but it is considerably higher in toxic epidermal necrolysis. Coming towards the inciting factors, as I've already mentioned, the condition involves a cell-mediated delayed hypersensitivity reaction, which is usually related to drug exposure. A wide range of medications have been incriminated, including antibiotics, especially sulfonamides and trimethoprim, analgesics, including paracetamol or acetaminophen, nevirapine, widely prescribed as a part of combination therapy for HIV infection, cold remedies, and anticonvulsants, infections due to microorganisms such as Mycoplasma pneumoniae and herpes simplex virus, and some cancers have also been implicated. Because symptoms often take weeks to develop, in many cases, the precipitant cannot be identified. Now, patients will present in the acute stage with redness, grittiness, photophobia, and watering and blurring. However, there are often practical obstacles to standard slit lamp examination, as the patient may be bedridden and undergoing barrier nursing. A portable slit lamp may be helpful in that case. Upon examination, we may see hemorrhagic crusting of the lid margin, which is characteristic, and skin lesions may be confluent, and it is often difficult for an examiner to open the eyes without causing marked discomfort. The hemorrhagic crusting can be seen in this picture. You can see these here, and forcing to open the eyes will be difficult for the patients. Papillary conjunctivitis, which can range from mild, transient, and self-limiting to severe. Conjunctival membranes or pseudomembranes can occur with severe hyperemia, hemorrhages, blisters, and patchy infarctions. Here in this picture you can see this membrane in this area. Now, which it seems to be a pseudomembrane. Keratopathy is a spectrum of lesions from punctate erosions to large epithelial defects, secondary bacterial keratitis, and occasionally perforation. Iritis is not infrequent, and panophthalmitis has been also reported. Late signs include conjunctival cicatrization with formicial shortening and symblepharon formation. As it is seen here, there is conjunctival scarring in this picture, keratinization of the conjunctiva and leg margins. As you can see, that the keratinization is extending from the skin into the cornices, and it is accompanied by abrasive plaque formation sometimes. Eyelid complications include cicatricial entropion and ectropion, trichiasis, metaplastic lashes, and ankyloblepharon. Keratopathy includes scarring, vascularization. In this picture we can see scarring in this area, and it is covering the visual axis as well. And as a result of the primary inflammation or infection, as well as cicatricial entropion and aberrant lashes. Watery eyes due to fibrosis of the lacrimal puncta. Dry eyes may also occur as a result of fibrosis of the lacrimal gland, ductules, and conjunctival metaplasia with loss of goblet cells. Now, skin biopsy may help to establish the diagnosis, but is rarely necessary, as the diagnosis is usually clinical. Patient will present with the symptoms which are flu-like, which can be severe, may last up to 14 days before appearance of lesions. In many cases, the patient is very ill and hospitalization is required. Symptoms of systemic mucosal involvement include nasal pain and discharge, pain on micturition, that is pain on urination, diarrhea, cough, shortness of breath, and pain on eating and drinking. Signs include mucosal involvement, which is characterized by blistering and hemorrhagic crusting of the lips, as it is seen in this picture. The blisters may also involve the tongue, oropharynx, nasal mucosa, and occasionally the genitalia. Small purpuric, vesicular, hemorrhagic, or necrotic skin lesions involving the extremities, face, and trunk. These are usually transient but may be widespread. Healing usually occurs within 1 to 4 weeks, leaving a pigmented scar. Widespread sloughing of the epidermis is uncommon. Targeted lesions or targetoid lesions show classic 3 zones and are now viewed as characteristic of erythema multiforme rather than Stevens-Johnson's or toxic epidermal necrolysis. Now, the first modality of treatment is removal of the precipitant if possible, such as discontinuation of the drugs and treatment of the suspected infection. General supportive measures such as maintenance of adequate hydration, electrolyte balance in nutrition, especially protein replacement, are critical. Management in a specialist burns unit should reduce the chance of infection when the extent of skin involvement is substantial. Systemic steroids remain controversial. There are reports of increased mortality in older papers, but later research has raised the possibility that early short-term high-dose intravenous treatment may be helpful and improve outcomes. Other immunosuppressants such as cyclosporin, azathioprine, cyclophosphamide, intravenous immunoglobulins may be considered in selected cases, but are controversial and controlled trials are lacking. Systemic antibiotics may be given as a prophylaxis against skin or other systemic infections, avoiding those known to be at high risk of precipitating a Stevens-Johnson syndrome. Now, coming towards ocular treatment of acute disease include daily review, initially in most patients to check the corneas and exclude symblepharon formation. Topical lubricants are used as frequently as necessary. For example, Hypromelose 1-3%, preservative-free up to hourly, high viscosity ointment during sleep, prevention of corneal exposure, for example, moisture chambers, gel pads if mechanically ventilated. Topical steroids may be used for iritis and for conjunctival inflammation, though a benefit for the latter has not been demonstrated conclusively. Topical cycloplegia, for example, atropine 1% once or twice daily, may improve comfort. Lysis of developing symblepharon with a sterile glass rod or damp cotton bud, a scleral ring consisting of a large haptic lens may help to prevent symblepharon formation, as it is seen in this picture. You can see a large haptic here, and then there is pseudomembrane or membrane peeling, which can be considered, although the benefit is yet to be proved. Treatment of acute corneal problems such as bacterial keratitis, conjunctival swabs should be considered for prophylactic culture. IOP monitoring may be prudent using protocol tonometry if necessary. For the chronic disease, adequate lubrication, including punctal occlusion if required. Topical transretinoic acid, 0.01% or 0.025% may reverse keratinization. Treatment of aberrant lashes, bandage contact lenses, typically gas permeable scleral lenses to maintain surface moisture. Protect the cornea from aberrant lashes and address irregular astigmatism. Mucous membrane grafting, for example, buccal mucosa autograft or for pharyngeal reconstruction. Corneal rehabilitation may involve surface keratectomy for keratinization, lamellar corneal grafting for superficial scarring preferred to penetrating keratoplasty, amniotic membrane grafting, limbal stem cell transplantation, and keratoprosthesis implantation in the end stage disease. So this is where we're going to conclude the subject of Stevens-Johnson syndrome. Thank you all.